be providing providing the recording. I'm going to be providing all of the follow-up material to Karen after today's session, so that you all can have access to that. Here we are again on day 2. Let me go ahead and share my screen here. Perfect. So we are here on day 2 of the winners and losers in the shifting world of employee benefits presentation. So this again is kind of self-funding basics. I am Grant Parker. I was with you yesterday. So if you were here yesterday, I'm obviously familiar to you. We're joined today by Kevin Schlotman, who is on my team. He's a member of Flume Health, kind of one of the founding members. He's our Chief Client Officer, and his pedigree is very impressive. So I will actually just give Kevin a chance to introduce himself quickly.
Grant, great opportunity to meet everybody today and bring some information hopefully that you find useful. Just by way of kind of background, I've been in the insurance industry for going on 25 years, a little less than half of that on the property and casualty side. I've been in agencies and brokerage until really I joined Flume. We also had and operated a healthcare TPA. So that's how I got into the TPA space, roughly 2007, 2008 timeframe. I've tried to remain active in the industry, national associations and things like that. So we're excited to bring you some information today that hopefully you find helpful.
Yeah, thank you very much, Kevin. So Kevin's going to be doing a lot more of the speaking today. These are his areas of expertise, especially in the stop loss and risk and reward and things like that. Just to give a quick reminder about what we covered and what we talked about yesterday, there was really good questions, really good conversation. I really hope that that will continue today. So yesterday we talked about very high level, talking about and selling self-funding. What is the value prop of a self-funded plan? Why should we be trying to break away from the BUCAs in the fully insured world? And then we talked about the key places to save money. So very specific cost containment tactics that can be built into these plans. Some that people seemed familiar with, some that people seem skeptical of, some that maybe hopefully you had not heard of too much before. But we gave a good long list of those and resources to look more into that later. You know, again, the keys from section 1, the key takeaway there were about aligning incentives. Independent plan design lets you put partners in that will align their incentives with the employer, gives them the chance to win. Finding the right lead, looking for groups. Again, this isn't for everybody. We're looking for groups that are opinionated about their plan design and about what they're offering their employees. A group that is open to disruption, and a group that wants control and wants data, because that's what these plans are designed to give them, data and control. And then the value of thinking long-term, right? So putting a multiple year plan in place, not jumping right into the deep end of self-funding, but really critically thinking about where this group is trying to go, what are their goals, and what is the best plan arrangement to get them there now and over the next 5 years. And we'll be providing a one-pager that is employer-facing. We'll be providing a template of qualifying questions that you can use to kind of, I would say, probe. They're probably a little bit different questions than you might want to be asking for groups that maybe would be fully insured or would be good for that. And then links out to mentorship. We had a very specific question about how can we learn more? How can we get deeper into this? There are organizations that you can use to level up your skills and to grow your community. So Health Rosetta and Masterminds Network are two that I would really recommend that people get involved in. So we'll be providing links to those after this session. And then a summary of section 2, key places we save money, right? The main thing is forget the discounts. You've got to get out of the game of competing on discounts, because every broker has the same discounts. It's all commodities, health plans, ASOs, everybody's got the same thing to sell. You cannot differentiate yourself as an advisor, and you really can't help the client win if you are only playing the discount game. You've got to start competing on plan design. You've got to start thinking critically and bringing value to the table. Otherwise, somebody else is going to get this account. Know the 12 levers, one or all of those that we were talking about yesterday, can have major impacts on how the plan runs and can help you put a really good plan design together. And then finally, third and finally, data is your friend. We looked at ways that we're using Coral.io to try to find savings opportunities. We looked at the ways we're using script sourcing. These are ways to start the conversation and just kind of show, hey, there's opportunities being left on the table. I'm the right broker for you. And again, we'll have some resources to take away. I've got video demos of all the things that we showed yesterday that you can watch over again, maybe even they're client facing. We've got a template for a claims request so that you can be requesting demo data for your groups. We had a question yesterday about how do you get this data? Where is it available? So we have a template and a resource to learn how to do that. And then we've got the RFP checklist, something that we touched on yesterday. You know, you're going to want to make sure that you have certain pieces of data before you go to market. We're going to speak about that in more detail today, but we've got a document that lays all of that out and makes it really clear. So before we move forward today, I'll take a small pause. Were there any questions or anything that anybody wanted to make sure they brought up just in regards to yesterday? Beautiful. Okay. Job well done. Great. Great. If anybody does have questions, you can put them in the chat. Karen was being awesome yesterday and watching that for me. So today we are going to continue talking about our self-funded basics. We've got 2 new modules for you. You're going to get your CE credits for those. The first module is Stop Loss 101, talking about risk and reward, talking to clients about why they should make this change and what's going to be involved. And then I want to get deeper anyway, into an understanding of what underwriters are looking for, how this works. We talk to a lot of advisors who want to get into this. However, they are not privy to the way that stop loss works. They are not experienced or involved in actually getting quotes like this from the data side, what's needed, but also just from understanding how this all plays out. And so Kevin is going to be here with us today and talking about that. There's a lot to learn. I don't really know everything about it either, so really don't worry. But we do want to introduce you to some of the basics and the concepts and things like that. And then we are going to dive deep into a couple of funding arrangements for groups. This is probably the place where we have the most misconceptions, or that we hear the most misconceptions from advisors and brokers, really understanding the difference between PEOs, level funding, captives, reference-based pricing, really not quite being sure when to apply each one, thinking something's good for somebody and it's really not. So I want to explain the difference between these different types of self-funding arrangements and have you walk away knowing when to use each. Cool. So let us dive into Stop Loss 101. There are a couple of terms that I want to define when we start talking about stop loss. It seems to me, like when I got into this, the stop loss people had like opened the dictionary and picked random words that had one meaning and just decided that they were going to give it a completely different meaning. And so it took a really long time to get to know those things. So I think the 2 biggest terms that it's really important to understand are around the deductibles, your specific deductible and your aggregate deductible. This is a little graphic. I didn't make this. That's why it doesn't look very pretty, but I think it does a very good job. So Kevin, can you maybe start with spec and then go into ag and just explain, like, what do these terms mean?
Yeah, sure. And I think this actually does a pretty good job laying it out and making it very clear, right? So most stop loss programs have 2 coverage parts, right? And they can be completely separate. They can be underwritten by different carriers even. It's unlikely, but it can happen, especially if a group's a little bit larger. But the specific deductible applies to any individual, meaning claims for one person. There are some blues carriers that will do a specific deductible that applies to a family group or a family unit. But by and large, when you buy specific coverage, you're setting the threshold up to which the plan is responsible for claims for any particular person. And one of the things that I often hear, and maybe not with the folks on this group on this call, but I do point it out, right? It's independent of the actual benefits that the member experiences, right? So you may have a $50,000 specific deductible, but the member's deductible is still $1,000 with 80% co-insurance up to whatever the defined out-of-pocket maximum is, right? Which is subject to the ACA limits. So we see people getting confused by, oh my gosh, one person's going to be responsible for this. And it's not what the person's responsible for. It's at what point will the employer be reimbursed for expenses? That's what it comes down to. It's much more closely aligned to a property and casualty product like an umbrella or something with a self-insured retention. So specific applies to a specific person almost all the time. Do keep an eye out if you're competing against a Blues plan in certain geographies. It could be by family unit, right? And then for most groups that have fewer than 350 to 400 employees, aggregate coverage for the group as a whole is largely appropriate. Once you get above 400 or 500 employees, it becomes a sleep at night coverage that many employers will forego.
A what coverage?
A what?
A what coverage? Something about the night?
Sleep at night, right? So when you get to 400 enrolled employees, actuaries dial in the costs to within a very small percentage of variation, right? It's very unlikely that you're going to have an aggregate claim when you have 400 or 500 employees, because if you do, it means someone really didn't do their job right. Someone made a mistake, underwriter's getting fired, right? Something went wrong somewhere, and not just a bad year. But to take a step back, the aggregate coverage reimburses the employer, right? So this is an individual, so it's not even the plan itself. Usually it's the employer, reimburses the employer for a bad claims year overall, right? Meaning the entire group outran the expectations. Aggregate coverage, there's usually a deductible that's specified up front based on the initial enrollment, and that usually is a minimum. So if enrollment goes down, that minimum attachment point doesn't go down with it. One other question that comes up maybe once or twice a year, generally speaking, you'll see aggregate coverage with a $1 million limit. Again, this doesn't apply to a specific individual. There's no limit per person or claim diagnosis, but for the group as a whole, the plan would be reimbursed up to $1 million. And the question comes, well, what happens if there's more than $1 million in excess claims? And the answer is it would go back to the plan, right? It would then revert back to the plan to be responsible for those, which makes people anxious from time to time. But when you look at what the overall total cost of a plan is, right, and what the claims are, the likelihood that you're going to exceed not only the aggregate attachment point, meaning having the worst case scenario year, then pay $1 million more in claims is almost impossible from an actuarial perspective. So about once or twice a year, we get a request for someone to add another $1 million to that. Some underwriters are willing to do it. Usually they ask why, and we say that's because that's what they want to be able to sleep at night.
Sleep at night. Okay, so I have let me ask you a couple of follow-up questions there. So specific deductible, once you understand it, actually makes a lot of sense. It applies to a specific person. Each person is looked at individually. And the question is, how much claims does this person have to rack up before stop loss kicks in for that person?
Yep.
Whereas aggregate is the group as a whole. How much in claims does the group have to receive, regardless of who received them, before stop loss kicks in?
Correct. One point I'll make is that the aggregate only considers claims that are paid up to an individual specific limit. Right. So, once you exceed that and the stop loss, specific stop loss policy is reimbursing for that patient, those claims don't count towards the aggregate. So
it only counts for what stop loss didn't already pay for. So stop loss doesn't have to pay for it twice.
Yep. You don't get to double dip.
Got it. Okay. So let's apply this with some practical information for kind of sales. You mentioned something that I thought was really important, is that this is very similar to the way that P&C plans are priced and thought about. And I tried to make the connection yesterday that if you're talking to the head of HR, they're probably not going to be involved in this. But if you are pitching to the CFO and really making this about a financial decision for the company and for the group, tying this back to supply chain and the way that the operations of the plan of the company are run, there's already a precedent for groups to think in this way because they're already using this in their P&C plans. Can you talk a little bit about the connection between P&C plans and these health plans and why it's actually not that big of an ask for a group to think about this way?
Well, yeah, I mean, particularly if you've got 100, 200, 300 employees, you're likely to have, a sizable workers' compensation exposure, right? Your manufacturing, your construction, you're likely to have a sizable auto liability exposure. You've got, bucket trucks out on the road, and there's liability associated with that. You may have a product, right? So if you're manufacturing a product, you've got liability associated with that. And the CFO, CEO will think about their life on a daily basis as we've got risk every single day. We're selling something into the market, it could hurt someone. Or we've got trucks on the road that could have an accident and someone could get hurt and we can be responsible for that. Or we've got people using machinery and we've got to make sure that they're safe, right? And actually, one of the things that I credit with helping me in my career was having that property and casualty background and then applying it to healthcare. Because people who've grown up only knowing health insurance, or individual or group, either way, they don't understand risk the same way as someone who's had to build insurance programs for organizations that have a substantial liability exposure, right? So,
what are people if not a liability exposure?
What's that?
What are people if not a liability exposure?
Exactly, right. And if you approach it from that perspective, I think it makes the concept of lasers a lot more tolerable, right? And I think there's a chat that came in and asked about lasers, and I know you addressed this a little bit yesterday, but we can dive a little deeper today because we're talking about the mechanism here. When it comes to a laser, generally speaking, there are two ways to approach the risk associated with a known claimant, right? This is somebody that we know is sick, someone that we know has a condition, and we have an expectation about what it's going to cost, right? So we know this patient is spending $30,000 a month for their chemotherapy treatment. They're going to spend $360,000 over the next year. How do we deal with that, right? Insurance on the property and casualty side, for sure, right, is about addressing the unknown. So we have a known, and stop loss insurers are going to address that known claim the same way they would in an auto liability or general liability. There's going to be a deductible, or it's going to be carved out, what's known as a laser. And we traditionally have seen those as an opportunity, and that's not just a spin, right? It is an opportunity to affect the cost. Historically, lasers have worked to the benefit of the employer in excess of 85% of the time. Now, what do I mean by that? So using our cancer example, we've got $360,000 expected over the next 12 months. A couple of things happen, and generally speaking, they work to the employer's advantage. Because if you carve out that $360,000, you don't have to pay for it in premium, right? It's your risk as the employer. You're going to pay for it one way or another. You're either going to give it to the insurance company in a form of premium, and they take the risk, or you keep the risk and pay as you go. So I think that's an important concept to work around.
This was a question that came up yesterday as well about the lasers and how that works. The laser from this perspective that Kevin is saying is a laser is merely a way of looking at how you want to handle the risk, particularly known risk.
Exactly.
It's not about not giving them coverage. It's not about getting them off the plan. It's about managing and handling that known risk.
Exactly. So what happens and how this inures to the benefit of the employer, right, is that 85% of the time historically, and this isn't just my experience, this is an industry rule, as far as this can be a rule, either the patient drops off the plan, they go onto a spouse's program, they're no longer with us, or collectively find a way to mitigate some of that risk, right? So we take that $30,000 infusion therapy, get it away from the provider buy and bill. I mean, the grant addressed this yesterday. It's one of the levers, right? White bagging, J-code infusion medications, and we're able to substantially reduce the cost. Whereas had the employer just taken the increase in premium, they would be guaranteed to pay that premium for the entire 12 months. So these are the kinds of conversations that you have at renewal, right? What do we know, right? Do we have an expectation about, the mortality of the patient? Do we know what they're doing? Can we affect the cost? And if so, can we do it on terms that make the most sense for the plan sponsor? So lasers are a tool, right? Now, what's interesting about how they've evolved, or more about how our collective world has evolved, to include medications that are essentially maintenance medications, like Stelara, like Humira.
$20,000, $30,000 a month drugs.
Right. So whereas historically we had individuals in the course of treatment for a known diagnosis that was almost always temporary, right? They were going to get better and recover, or they were going to fall off the plan because they could no longer work, or they were going to perish, right? Now we've got the scenarios where we have a known ongoing expense that's going to continue year over year, right? So we look at a Humira that could be 120 grand, and a Stelara that could be 240 grand. If you have a 100 employee company with a lower specific deductible, we're gonna see lasers for those people, and it's gonna be a known cost, right? And someone's got to bear the cost, or we have to mitigate it. And I know Grant talked yesterday about how there are tools in the market to be able to do that, right?
Yeah.
Find manufacturer assistance programs, find opportunities to internationally source medications if you're good with that, and ways to mitigate some of that risk.
Yeah. So again, we're getting away from the mentality of treating every member the same and buying off the shelf. And we're getting into the critical thinking about plan design. What are your cost drivers? How do we specifically address those to make a change in your plan?
Exactly.
So one other question that I had, you're actually speaking to a lot of things that we have slides about, so this is really good. Which of these, the spec or the ag, which of these is going to affect the stop loss premium more? Which of these can we get more aggressive on? Like which of these is the button to press to try to bring down some costs?
Yeah, it's a great question. The bulk of the premium is going to be in a specific coverage, right? That's where the risk is. Thanks to the Affordable Care Act, it's now unlimited, or you should be making sure that any specific you buy is unlimited, right? I mean, so in the world of $1.2 million COVID claims, that's where the risk is. The aggregate is, generally speaking, much less expensive, right? So you're going to expect to spend a couple $100,000 or more for specific coverage, and you're going to spend somewhere in the neighborhood of $10,000 to $30,000 for aggregate coverage, depending on size and other factors. Karen, you got a question from you?
We do. So there's a couple of questions in the chat that are talking about lasers.
Mm-hmm.
When do we laser? How do we laser? One of the questions was specific to ask about a large number of individuals who are lasered on COBRA. So can you address their concerns?
Sure. Let me just take a look at them real quick. It's interesting how COBRA's evolved in large part thanks to the Affordable Care Act. A lot of people can get free to nearly free coverage on exchanges with tax subsidies. And a lot of those individuals that are no longer employed are gravitating towards that if we can make sure they understand that it's a good deal for them. From the perspective of the stop loss carrier, and frankly from the perspective of the self-funded plan, there's no difference in eligibility, benefit, or terms that we're going to see between someone who's actively employed or someone who's enrolled on the COBRA benefit, right? They are the same. They're going to be underwritten the same. It's one of the reasons why when you go to launch one of these programs and you're completing the paperwork that includes disclosure, right? You get a statement that the employer is going to have to sign that says, these are the people that I know of that are not actively at work because they're sick, or they're hospitalized because of a surgery, or they also ask to identify people that are enrolled on as a result of COBRA benefits or that are eligible to enroll under the COBRA benefit, because they're going to want to look at those individuals and see if there's risk associated with them. So I don't know if that answered the question or not. You know, I wouldn't say that there's a higher percentage of people that are enrolled in COBRA that are lasered than those that are not. I think it ties back to the risk tolerance of the group and the community, right? Sometimes there are people that are very risk averse because they've been they've had health issues that they've had to deal with, and they're more inclined to immediately elect COBRA versus a lot of people who are going to roll the dice for 60 days and hope that they don't have any conditions and find another job.
Okay.
How was that? Did that answer the question? Do we need to go deeper on that? We can also talk about it, you know, after the class and things like that if people have more specific questions.
So when those are on COBRA, those with lasers, this is just going to lead to a COBRA comment, is we find that those who are on COBRA really don't want to take advantage of the cost saving measures that an employer has available to them on the programs they're in. So what's your experience with that, and how do you encourage that?
Well, it depends, right? If there's no financial incentive for them to take the telephone call, they're not going to listen. So, you know, most of our plans, right? And again, this isn't a Flume advertisement, but I can tell you what we've done and we've had some success with. Most of our plans financially incentivize patients to take the call and listen to the advice. Are we going to be successful getting them to go to a bundled surgical arrangement that's 125 miles away? Probably not. Are we going to be successful telling them that they can get their Stelara for free when they otherwise would have had a $6,000 out-of-pocket expense associated with it? We get more interest there, right? So very true that we're not going to drive certain types of utilization, but we can sometimes get them to participate in free, right? And it's more than worth it for the plan sponsor to pay that $6,000 amount to save $240.
Well, do you think, this is to Kevin and Grant, do you think that more or less the success of being able to utilize those programs to the best of their ability really lies in the rollout and the communication? Sorry about that. And communication beforehand. Like my experience with reference-based pricing and some of the larger accounts that we have in self-funding is the employees really, you know, they don't really care. They're going to stick it to the employer. They don't really care about the employer's budget. They care about themselves. So to get through that was, you know, it's always an obstacle. You know, a pure example would be something you would deal with that kind of addresses the question that's in the chat. And that would be a large client. He is in a reference-based pricing program, you know, the flex program. So they had a choice, go in one way or the other. And there's a person on the plan who has MS. So the drug for that particular employee is like 15 grand a month. And she just refused to go through the process of finding it cheaper. So it was a huge spend on behalf of the employer. Our recommendation was that the employer put an incentive for her to take the phone call as opposed to not. And she was a COBRA to that point. You know, and she just didn't feel she should have to do anything. But is it the incentivizing that really gets the attention? You know, making sure that we introduce that from the very out of the gate.
Yeah, I know this is really what Grant does exceptionally well for our clients and his team. I'll say this, for people that have that type of a chronic, ongoing, known condition, we do find that some of them are have a sense of entitlement and approach healthcare from the perspective that the insurance company, and we all know this isn't insurance, right? But that the insurance company is trying to get off on the cheap, and I'm going to get low quality medications or service, and they're very difficult to work with, to put it as nicely as I can. Sometimes they're downright rude. The only way you can overcome that is with dollars and cents. And even then they may not listen. So we have to, those are scenarios where we can only do what we can do. But there's definitely an ongoing member education program that plants the seed. But, you know, what we've certainly learned is that It's most effective at the point of prescription, right? As close to the point where somebody has a new service they need, a new medication they need, a new procedure that they haven't experienced before. If we can touch them as close to that interaction with their physician as possible, we've got the best chance to get them to utilize the plan the way it's been built.
All right, to that's a really good point. That, you know, these are obstacles we have. The employees are just feeling they're entitled to a copay. That's it.
Right.
You know, they want everything paid at a copay, and that's kind of the philosophy they're following. And anything beyond that is an ask, unless, of course, I think it comes from the delivery of the plan in the beginning. So
No
I
doubt.
don't know.
It's, you know, it's an interesting conversation, right? We've had people argue that a stress test to make sure that someone isn't at risk for a heart attack is a preventive diagnostic test and should be covered at 100% because of the ACA. And the answer is that's a solid effort, but sorry, and it doesn't work that way. Right.
Yeah, it is a little bit of an entitlement mentality with regard to healthcare. But the big thing is that, all right, so we can bring that savings to the employer. One of the questions again in the chat addresses, so we'll put in a laser on this particular group that has this situation going on. The question was, can the employer add the laser cost to the maximum liability to calculate the premium? I believe the employer can charge whatever he wants, but
Right.
you tell me.
We're talking about the COBRA rate equivalent for sure.
Yeah.
And, you know, to be, you know, as fiscally conservative as an organization from a budget perspective as possible, that's what I would recommend.
Okay.
We have a known ongoing claimant, and we know we're going to reduce that laser by, you know, 60, 70, 80%, which can be the case with some of these medications. Then, you know, it's up to them how they want to deal with it. But for sure, the requirement for COBRA is simply that you have a reasonable method to calculate it. And that's the guidance. So there's a lot of flexibility built in there.
Okay. Well, thanks. I just took up a bunch of time with questions. So
No, these are,
We're here.
yeah, these are great questions, and this is the reason that we want to have this. So please keep them coming. Let's do move forward. However, just in this module, again, if there's questions, they are going to be captured on the chat, and we can definitely come back to them. But I want to get into a little bit, and this is Kevin's favorite topic, I know, about how underwriters think. Creating relationships, long-lasting relationships with underwriter carriers is the best way to put your clients into a good position to win. And so I think the first thing that really comes to mind about these underwriters is that they are inherently conservative. So Kev, do you want to talk just a little bit about, you know, what that means and what that means for a broker or somebody who's approaching an underwriter for some marketing?
Yeah, I mean, I've actually sat in underwriting chair, did some training with an insurance company many years ago. So I got, and you know, I've got to be friends with many of them. And they've all had a situation that's burned them in the past, right? They've all had a particular disease state, a particular course of treatment, and they never forget, right? Because the things that rise to the level of scrutiny are really, really expensive, and they're traumatic, right? They're big. They affect their overall profitability as an individual underwriter, which affects their compensation, right? So they can definitely be paid based on how well they perform from a risk perspective. And also they take their responsibility as, you know, a protector of their organization's, you know, profitability seriously. So, you know, because of that, they tend to look for holes or gaps in what they're presented, right? Because they're going to pick at that to try and figure out why something isn't the way that it should be. And that can mean, why don't we have as much information as we would like to have to underwrite this? It could be, why is there a gap in the claim information of 3 months? So, and I'm sure everyone here has experienced those scenarios where, you know, a TPA or underwriter is coming back to you and continually trying to find out why there's a little wrinkle here that they didn't expect to be here. And one of the things we can do collectively to try and avoid that is make sure we have established for them the rules of this particular client's game, right? So if we've got a fully insured customer for whom we have limited information because that's what the carrier offers and they won't do anything more, then setting that stage as part of the initial submission to them is a great idea. And I'm sure we're going to get to this a little bit later. But their mindset is there's something in here that I'm not seeing, and it's going to come back to bite me. So we're always trying to overcome that initial perception.
Yeah, I think the next point here is that, the way that these carriers make money is on good risk. So they need to be able to identify what's the good risk, or they need to be able to build around the bad risk.
Right. Yeah, I mean, when we talk about specific premium and it's going to be a couple $100,000, I kind of just toss that out there like it was nothing. When you look at the overall expense of the plan, it's roughly 20 to 30% depending on the size of the group of the total plan cost. So it's not insignificant, right? But think about the exposure that they have for that $250,000 or $300,000 they're collecting in premium. And when you contemplate the fact that $250,000 can be spent by one bad COVID patient, as an example, they've got to. That's the reason they're inherently conservative, right? They're trying to make sure they miss those things that they can identify in advance.
Yeah, absolutely. And I think that goes into, the more information that they have, the more aggressive they can be in the pricing. So what are, speak a little bit to the ways of how do we get these clients, these groups, a really good rate? Like, how do we financially beat out the BUCAs?
Well, I think that the key components really are the levers you talked about yesterday, right? What are we building into the program to manage the risk? Each one of those is risk management, right? So if you've got any P&C background, you know where we're coming from. We're taking little bits off the top of what they're going to have to pay because we've got these opportunities layered in. But at the basic underwriting level, making sure that we have the things that they need to check the boxes, right? Claims by month, enrollment by month, what the rate history has been, large claimant information. If that's not available, then we've got to tell them the story that they need to get comfortable around taking a risk. And it could mean individual medical questionnaires. There are new tools coming onto the market, one of which is an organization called Verify that we know pretty well. And there are a couple of other alternatives that we're just presenting at SIA, whose names are escaping me at the moment. So there are several in the market now that are attempting to recapture the concept of GRX or curve underwriting, right, where they can do some risk scoring based on census. But the more tools we can give to an underwriter to produce and put good numbers on the table that they know they can that we can sell, the key is more information, the better we are.
Yeah, I think the last point kind of sums all of these up is that they do not like surprises.
Right. So that's when you start going through the disclosure statement, and we send them a disclosure statement with nothing on it signed by the employer, and then all of a sudden we find out that there was somebody that was inpatient at the time the group went live, then they're going to be cranky about that. The other piece of this is, right, it goes into, and I'm sure we'll talk about this at some point later, but the big problems, challenges that we have revolve around eligibility, right? Someone forgets to take someone off the plan, someone forgets to add people to the plan according to the terms of the program, and once a quarter, if not more frequently, we're dealing with one of our stop loss carriers, or there's a scenario where someone has been allowed to remain on the plan who's exhausted FMLA, whether it's a published employer leave policy, or most of your customers are trying to do the best they can for their people. They treat them like family. And in an effort to do the right thing, they leave someone on the plan who is exhausted FMLA but is not on COBRA. That's a surprise from an eligibility perspective that a stop loss carrier doesn't really like, right? If there's going to be a leave, it needs to be defined up front. If it's defined up front, they're almost always willing to accept it as part of the plan. But if we come back after the fact, they're going to be unhappy.
Yeah, we're definitely going to talk more about sort of exposures and things like that. I want to move into kind of talking about this concept of total cost of ownership. This is kind of where a little bit all of this is leading. When we look at how a plan's costs break out, to me, it's very, very simple. We talked about this yesterday. Your fixed costs plus your variable costs equals your total cost of ownership. Going a little bit deeper into this, the fixed costs are all of the things that you can plan for. So your vendor fees, whether it's your PBM, your TPA, your network fees, renting networks and using networks are associated with fees. Sometimes even those fees can be variable because it's the network will actually charge a % of billed charges if you're using something like the network that you rented for out of state, in which case employers wind up paying twice for one bill. So that's something that you got to be really aware of when you're building these plans. Your stop loss premium counts as a fixed cost. That's something you can work on the front end and work with your stop loss carriers to try to reduce those fixed costs. But that's definitely a fixed cost. And then any of the processing fees are like setup fees for the plan. A lot of times there'll be a first year setup fee for the network or for the TPA or for the plan documents, things like this. These are all, they'll be laid out by the TPA or whoever's balancing the plan, but there's fixed costs. And then there's the variable costs, and that's very simply the number of claims and the cost of claims. And so the point that I want to make in bringing all of this up is that this ties back to what Kevin was saying about the 12 levers and what we talked about yesterday. If you can make an impact on one of these two areas, the place to try to make the impact is on the variable cost. A lot of the ways that plans are being sold today, especially in the fully insured world, is, oh, well, I can get you lower fixed costs. I can argue down this renewal rate that Cigna is putting forward, or I can lower the BUCA's overhead, or I can lower my broker fees or whatever, right? The focus has traditionally been on trying to address that fixed cost. But if you make a 20% impact on something that's only 30% of the total cost of ownership of the plan, you're making a 6.6% impact on the costs. Whereas if you start thinking critically about the way this plan is built and what the data is telling you is needed in order to bring down the costs and improve the outcomes, and you start putting in the levers in place that are going to affect the variable costs, how many claims you're getting and what kind of claims those are, a 20% impact on the larger piece of the pie is more than twice as much. You can be twice as impactful by designing a really good self-funded plan than you can negotiating and scrimping around for the best fully insured plan. It makes a much, much bigger difference if you start to think critically. And if you can get clients on board with thinking that way, and again, change this from an HR conversation to a financial conversation, you can go into a room and say, I know how I can double the impact of your renewal this year. Everything that you've been renewing before has been having a very, very small impact. I know of a way that we can double that impact. Is that something you'd be interested in hearing about? And Kevin, I don't know if you have any thoughts on this.
No, I think you said it as well as I could, right? We, as an industry, we spent a long time turning the screws at the wrong end of the spectrum, right? And, if we really want to make change in the long-term trajectory of any one of our clients' plans, the only way to do that is to manage the risk. Managing the risk means managing the claims.
Yeah, absolutely. And this is, I had actually planned to talk about this a little bit later on, but Kevin brought this up earlier, and I'm really glad that he did. This is exactly the way that these same clients' P&C plans are running. If you've got a fleet of vans, if you've got a bunch of X-ray machines that you rent out, if you've got whatever collateral assets in your business, you are absolutely thinking in terms of total cost of ownership. You're thinking in terms of risk mitigation. You're doing things every day to mitigate the liability along the full spectrum of your supply chain. Healthcare needs to be thought of as a supply chain. Why should this be any different? Most of your effort and most of your time should go into risk mitigation with a small cap for insurance on the top of it. That's how every other part of your business is being run. What we're asking you to do is start thinking about your healthcare in that way as well. What we have right now is healthcare that just insures absolutely everything and pays zero attention other than wellness and making sure people get their steps and making sure people have those diagnostic EKG tests. It completely ignores the idea of risk mitigation, and it just ensures everything out the wazoo. And if you really want to answer the question, where is my 15% renewal going? It's going to the fact that you are over-insured for something that you should be mitigating risk on.
No question.
So I have a question for you. So as creative thinkers as you are, and access to, and access to the variety of the 12 levers and how to do that, you know, and how to accomplish the goals that you're setting forth in the right partnership. If you were to have a magic wand and you were to say to us as a broker community or clients at large, you know, this is what we see as the best kind of designed healthcare that would protect you, your budget, and your employees, what would that look like for you? The part of the business that you're really in, which is why I've always been intrigued talking to you, is in this creative design and funding and making sure we cover a risk. You know, when I say to a client, well, you know, they're objecting to a deductible or something, and I said, well, it's like car insurance. You got a deductible for cars, right? Yeah. Each time you have an accident.
Right.
We only pay once a year. I never thought of it like that. Like the idea of health insurance is just so foggy because it's not something that can see, feel, touch. So if you were to do that, if you were to lay out, this would be the program that would support you the best. And then right away, I think the problem that I have had, or the challenge I've had in this discussion, is right away being able to lay out those 12 layers and here's how we support this, and this, high level. They don't need to know detail. And should you have, we were talking earlier with one of the brokers, should you have something during the middle of the year blow up, it's really easy to plug and play that in with something else. So how would you answer that?
I do want to say, I think that for larger detailed answers to that, the next segment, the next module that we're going to start at 12 or 12:05 is really designed to answer that question. If I had to answer that question, I would unfortunately have to answer it with another question, which is, well, where is the group starting from? What kind of group are we talking about, and where are they trying to get? There are so many more options out there than the 4 major carriers and their bronze, silver, platinum plans. We can get really granular and detailed. So maybe my answer to that question would be like, let's go through the second module and see if that doesn't shed a lot of light there.
Well, I'm finding to respond to that, as you're going to go to the second module, I'm finding some kind of designed plan around the silver plan seems to be attractive to employers. You know, that kind of a design where I do have first hour access, I'm not subject to deductible, we're paying attention to claims at a very high level. Like, I don't even think an employer realizes that when they're with one of the mainstream carriers, that those claims are just automatically being paid up to like 10 grand. That there's nobody really reviewing them.
Sure, they don't.
They don't even know that they've been triple billing. We moved a client, here's a perfect case in point. We moved a client, it's about a little over 200 less, from, you know, fully insured into self-funding, and it was a flex plan, so it has an RBC component, but it has exactly what you're saying. We have claims review. So we're finding when these people go to the clinic for care, the doctors at the clinic, also private practice, are being billed twice. Do you think Horizon would have caught that?
Well, they have no incentive to. I mean,
exactly.
They're actually incentivized not to, because the more they pay, the more they can make. If they need to drive higher revenue to their overhead, they have to pay more claims. That's a direct result of the Affordable Care Act, right? So they have no incentive to, right? The value that they bring, as Grant described yesterday, is in the value of their quote unquote network of doctors. So they're going to upset a patient and or a plan sponsor every day and twice on Wednesday before they're going to upset one of their key providers. And they may not even consider them key, right? It's the nature of the business and how it's evolved.
Yeah. We've got to get employers, we've got to get clients out of the business of BUCA interests and into the business of building plans that align with their interests.
Okay. So I just talking out loud, sorry.
Yeah, and I mean, I've been in, Kevin and I both can tell stories about that, like where, we had a group that had a $2 million preemie, and it didn't show up until months after anything had actually happened. Nobody at the plan was aware that this was going on. It took 2 years for the broker to try to pull data out of United, and United had no idea what had happened. They had no idea where the money went. They had no idea what the claims were. They were not able to answer the question of, okay, you paid $2 million in claims on my behalf. What were those $2 million? What were those claims? And they had no incentive to give that information to the plan sponsor either. It was a huge, huge, huge mess.
So in your experience in dealing with the larger employer groups, do you find that a larger percentage of them are attracted or implementing self-insured plans, stepping away from fully insured? You're more and more information coming out from what I'm hearing is a larger percentage of engagement in a self-insured marketplace.
100%.
Maybe moving from level funded to fully, self-insured, maybe not. You're finding that is to be the truth?
And yeah, I think that we're seeing that across the industry, right? So moving from a fully insured program, taking steps towards whatever type of financial structure they're comfortable with. It could be level funded, it could be it could be more traditional spec and ag, or it could be something like a captive. Yep.
So are you also finding in your interviewing of these larger groups, are you finding that the employers are intrigued at this management of managing their healthcare spend? They are intrigued,
The
right?
employers are asking for ways to do that.
Right.
So we have to get the C-suite in there, but be friends with HR, of course,
Right.
because HR just doesn't want to glitch.
Yeah, no, this has to become a business conversation. This has to become about the future of the business, and people are a part of that business, but this has to become about much more than how do we keep people from knocking on HR's door with complaints about their benefits.
So
Right.
I think I want to see from you, your organization, and organizations like you, the ease of the implementation is key. So we screw up implementation, we're out the next year. At least that seems to be the story. So, the ease of implementation, the guarantees behind what we say we're going to do, we do. That kind of stuff. I think I'll get much more buy-in as we can convince them that we're not going to screw up their day or not get a pharmacy paid or drop the ball as we move towards paying for things differently outside of mainstream.
Yeah.
Because it's just such a nightmare when something goes wrong.
Yeah.
Yeah, and there's certainly ways to try and mitigate some of the risks associated with the leverage you're pulling, right? And how do you step into it? And I think that was that was Grant's question before. Where is the group starting from, right? And what do we need to be able to demonstrate to them to gain their confidence and structure a program that is successful out of the gate? Because you can go from a fully insured cocoon to a reference-based pricing plan and save it 30 to 40% right off the bat. And if things aren't explained properly and the skull and crossbones associated with patient access issues, followed by some balance bills, even though they're still relatively rare, aren't fully understood and internalized, you're going to have, someone who's not going to be happy with you.
Oh yeah, exactly. Obviously we have experience there.
I think we've all got the battle scars, right? So that's why we're here, is to help pass along what we learned the hard way.
I will say that this reminds me of in the, I don't know, maybe early 2000s when we were rolling out high deductible health plans and we're funding deductibles with HRA, HSA. It was same pushback. Even though this is about a lot more money and a lot more rearrangement, it's the same pushback. I don't see how that can work for me.
Right.
Yeah. So it's the same kind of shift in refinancing your healthcare spend then as it is now. It's very interesting.
Yeah, and the interesting thing about that is we were focused on the dollars at the bottom, right? And the carriers gave us an opportunity to use that arbitrage, the difference in rates that they overcompensated for, frankly, to get a win on the bottom end of it. Now, when you look at self-funding, it's completely the opposite. We're focused on the top and trying to bring it down from the top down.
Oh, that's true. Philosophically, it has switched. Well, yeah, the carriers say, oh, you're using an HSA for funding. Well, we're just going to increase your premium 4%.
Right.
Well, we haven't spent the money, but they're going to increase it anyway because you're funding them.
Right.
Yeah.
And even if you're putting money into the HSA, all you're doing is just prepaying for a claim that you're still doing nothing to try to mitigate the cost of. It's just moving money around. It's not doing anything to actually affect the outcome.
Right.
Oh, I know.
Yeah, we're not huge fans of them.
So I think where this is a great conversation is our middle market where we don't have claim story, where they won't give it to us. We can only guess what it is. We have no idea what's going on.
So that brings me to, I'm really glad that you brought that up because it brings me to the next section of our lesson, which is if you can't get data. So there are, this is not exhaustive by any means. What I wanted to do was surface a couple of services and options and opportunities that we get a lot of questions about and that we suggest a lot. Bring them up here, put them forward, maybe answer some questions if you all are already familiar with these things. But yeah, just talking about if you can't get the group data, there's still options, right? So the first, and it belongs in here because it's a list, is IMQs. I think probably everybody is familiar with this at some point. It's very important. I wanted to point out it's got to be every eligible employee. We get a lot of questions. Oh, well, they're not gun enrolled, or we're going to laser them, so we don't need to fill that out. That just elongates the process and makes it much more burdensome. If you're going into IMQs and we're trying to get stop loss quotations and things like that, we've got to get every eligible employee to fill out the form. It's a very heavy lift. It's probably something that virgin groups are going to want to do, or groups who are really stuck where they are. This is kind of a Hail Mary pass. There's a very standard standard form type for the industry and ways to submit them. And so the first thing that we wanted to bring up was IMQs.
Definitely a course of last resort.
Yeah, the Hail Mary. The next one that I wanted to surface, it's a program called Rover. Maybe you've heard of it, maybe you haven't. It's definitely growing very, very quickly. But Rover is a technological way to approach this exact same problem. In this, when you engage with this program, members actually provide the login to their previous carrier's online portal, and then Rover's web scraping technology actually can go in and pull all of the EOBs and then aggregate that into a medical history report. So in some cases, it can be much more accurate than IMQs or even some of the carrier reporting that people can get. And it also tends to be easier on members. All they have to do is provide the login information. Rover even actually provides, for brokers who participate with it, client-facing and member-facing services to try to overcome that. You know, the objections would be, I don't want to give out this information, or what about HIPAA and things like that. However, groups that are employing this are finding really good success getting the right kind of data. And the reward for the members to participate is we can get you a much better priced health plan if we have this data. It's a subscription service that's usually paid for by the broker and can kind of come in on groups where data is lacking. So Rover Analytics is one that I would suggest looking into. And then also there's a new player on the market. It's called Radion Health. It's a new health plan from Verikai, which is what we mentioned earlier. Essentially, this uses a massive claims database to score members' risk based solely on the census data. So this does require a complete census. Every single employee in the company must be included in the census. And Radion is a health plan. It's actually a packaged product that you as an advisor and broker can go out and sell. It's priced very competitively because of their expertise in this data. And really, you don't need all that much to get started with it. So if there are groups that are wanting to take a step in this direction that do not have very good data, and you are kind of wanting to bring something forward to them without, spending tons and tons of time and thought processes on being critical about the plan design, Radion is actually a really great plan to put these groups into. It's a simple step for them. There's a network. It looks very, very comfortable for a group that this is new for, but you can get them into a really well-priced self-funded plan. And it looks like there might've been a question that came through in the chat.
There was, I think it was related to Rover, and the question was, how does it not violate HIPAA? And when it comes to Rover, the employee signs off on the process, right? So they understand that it's not going to be used for anything other than underwriting. It's not going to be returned to the plan sponsor, right? So they authorize access. So it's an affirmative opt-in from the employee. Let me take a second to address the HIPAA elephant. Our plan sponsors, particularly those who are self-funded, but theoretically, those that are fully insured as well, have an obligation to the employees on their plan. ERISA requires them to make sure that plan assets are spent prudently. And that includes reviewing everything about the operation of the plan, not just the fixed expenses, not just the premiums, but every claim dollar at some level or another, right? They have to take steps to audit plans on a routine basis. There's an expectation that they know where the dollars are going and that the dollars are going to the right place. So insurance companies and others in this industry and hospitals, in particular healthcare providers, have taken HIPAA to an absolute extreme and created the world's biggest privacy boogeyman. And they hide behind that. Largely to protect their own position, to keep people from getting access to data that they need to make informed decisions about how their plans operate. PHI, protected health information, absolutely needs to be treated extremely carefully. It needs to be limited access to only those who need to know. But the reality is, plan sponsors have an obligation to be reviewing them, right? And the carriers and the hospitals have, and the healthcare providers have inserted HIPAA as a block for us to be able to do our job, us being plan sponsors and their advisors. So I don't want anyone to think that I treat, or we would ever treat, or your TPAs should ever treat PHI cavalierly. It's very important to make sure people's identities are protected. However, we also have an obligation to the plan itself, right? For the benefit of the employees to make sure that it's being spent properly, and that includes reviewing claim data, right? Now, the other argument that I've made many times with our regulatory friends in DC, especially for our groups that are 100, 200, 300 employees, many of them are centrally located. Almost all their employees are in the factory or coming into the office every day to pick up their truck and go do their job, right? Employers know who's sick because they're not coming to work. I think someone may have made that comment and that point yesterday. And we have to acknowledge the fact that there's a reality to how all of our organizations operate. And it's not about prying, it's not about getting personal, right? We know, the employers know, and they have an obligation to make sure that that's being done right.
Yeah, absolutely. Thank you, Kevin.
I'll get off my HIPAA soapbox, but
Yeah.
I feel too often it's been used as a tool to keep people from doing their job.
Yeah. And I know we got a comment here. In my experience, getting the data is so important and the best way to get the lowest rates. Completely agree. This is the thing that we probably have the most conversations about, is getting the data. This is the thing that takes the longest in the process, is getting the data. So we, this is 12. I'm not trying to stem conversations or anything, but we do, this is for CE credits. There are certain things that we need to do in order to make these CE credits valid. One is ask quiz questions. Two is cover the material presented. And so I do want to move us forward. I'm going to try to reserve time at the end where we can actually go back to the questions in the chat. But in the interest of making sure that everybody gets their CE credits, I do want to move forward into the quiz question and then close this module out. We'll take a break and then we'll come back into module 2. So we're going to move forward into the quizzes. We're going to move forward now. We will come back to questions that are in the chat when we can. But I want to make sure that first and foremost, we do what we came here to do today, which is cover the material and get our CE credits.
Oh,
So I'm quiz question number 1. This is based on what we were talking about in the previous section.
1-minute break. Can I call you right back?
It should be very, very simple. Which of these affects overall plan cost more? Is it the fixed costs or the variable costs? And just like yesterday, you can feel free to put your answer into the chat and we will collect that. In the meantime, I am going to go ahead and move back through these chats and make sure that we're here to address them.
It looks like everyone's listening to you, Grant.
All right. However, it's very rare. I really appreciate it. Yeah, so absolutely. The variable costs it could be 200%. It could be twice as effective to address the variable costs as the fixed costs in the plan. And so, like I said, I want to try to close out this module because we're getting close to the break. 4 things that I think are really important to keep in mind as the TPA's role in all of this. Again, trying to always keep that in mind is the TPA should be keeping the stop loss carrier relationships strong. They should be helping to guide these conversations. They should be helping to keep the group and the stop loss terms in very good regulatory standing. Kevin made a point earlier about the eligibility and the way that it's properly managed. The TPA should be providing insight and guidance on the way that the stop loss terms are set up and how eligibility is happening throughout the year, because a group can be exposed to a lot of liability if FMLA runs out, but the member's not on COBRA or a claim comes in, or if a member was supposed to be termed but wasn't, and then there's only 90 days really to fix that. If a member racks up a claim and should have been termed but wasn't for some reason, the plan is still fiduciarily liable for that claim. So this kind of stuff is really important. And your TPA should be providing insight and guidance on this. And then again, it should be making sure that disclosures happen to the stop loss carriers, should be kind of guiding those conversations between the client and the stop loss carriers so that there are no surprises. And then we're going to sum up section 3 in 3 kind of points. One is attack variable cost. It has a much bigger impact on the total cost of ownership than attacking the fixed costs. Bring clean data. Stop loss carriers are naturally risk averse. They need to know what they're getting into. And no data, no problem. This is obviously a little bit tongue in cheek, but groups with weak or no data can still get covered. There are options out there for them. This is something that you as brokers and advisors should know about. These are things you should have experience with, or at least be able to bring to the table as a way to add value to these clients. So we are going to take a break now. It is exactly the time is 12:08. And so why don't we be back here at 12:15.
Okay, thanks.
Thank you, everybody, so much. We will see you at 12:15.
Karen, are you on? I guess she's muted. No.
I'm on, Rochelle. What's up?
I've been trying an hour to fax you the sheet and it keeps coming up busy.
Well, why not?
What?
I don't know. I don't know what to tell you. Our fax in the office is working fine. So why don't you take a picture with your phone and just send it to me with your phone?
Smart move. Thank you, Karen.
Oh, no problem.
That makes more sense. God forbid I should have realized that.
No problem. So send it on over that way.
Okay, thank you.
You're welcome.
Hi, Norma, how are you? All right, let me check it while I have my 5-minute lunch break and I'll call you right back.
All right, how are we doing on people being back here?
I'm back. We shouldn't have the music on because I don't know how to mute it.
Glad yesterday Karen asked for some music, so.
Well, that's because I was doing other work in the interim. No, Grant, can I speak over the music real quick?
Yeah,
When
here,
you
absolutely.
when you were first talking about this stuff, I noticed that like with carriers that runoffs could take 3 to 6 months, and we haven't discussed that yet. You're gonna be discussing how you figure out that carrier runoffs. In other words, like a 12-month policy period, but it goes 15 months or possibly 18 months on the runoffs on prior claims.
Yeah, I actually did have a slide about that. It was something that in order to kind of keep us on time, I
Oh, okay.
skipped
Okay.
over. But Kevin, do you want to speak to that now?
Yeah. Generally speaking, you will set up a program to either be backwards looking at 24/12 or forwards looking at 12/15, meaning claims incurred in the next 12 months or paid in the next 3, or maybe looking backwards, claims incurred within the last 24 months but paid last 12 months paid but paid within the current 12. And then you have to account for claims if you move back to a fully insured plan or any other program. Really, you want to make sure that claims that are incurred prior to the termination of the program are accounted for, right? So runoff.
Right.
And
What happens when you go from one self-insured to like I step in and pick up another carrier's self-insured program, and how do we deal with that runoff? Do we deal with it or do they deal with it? And if it goes beyond the 15 months, it goes to 18 months. Do we pick up the extra 3 months if there's any straggler bills that still coming in?
Yeah, so keep in mind that
incurred?
Yeah, it's always going to be on the employer.
Okay.
And the tail period. So let's just say we're talking about a 12-15 contract where you've got claims that are incurred in 12 months, so let's say the calendar year, but then paid in the following 3 months are subject to the stop loss reimbursement. It's my recommendation personally that only applies to specific coverage, because what we're really looking to do is to capture any late, unknown, large claims, right?
Okay.
The aggregate piece of it, for most groups, we get to smaller groups, it's a little bit different because they got a lot of fluctuation from month to month. But for most groups, the aggregate piece of it's fairly well known. You're going to have 30 days of claims that are going to be roughly similar to what you would have had in a normal month. And then the claims drop off pretty precipitously. Most run out periods will coordinate with the timely filing provisions of the plan, right? So doctors and hospitals have a certain amount of time to submit a claim after the date of service, right? It can be 6 months. Most of the time, in my experience, it's a year. They've got up to a year to submit a claim. Why they would take that long, nobody knows, but they can. And then as long as the claim is received within the timely filing notice, the plan would pay the claim. But once you get past the 45-day mark, the volume of claims goes down very rapidly. And we have stragglers that can leak out into 4, 5, 6 months. But they would just go back to the plan to be paid just like they would have otherwise.
Right.
Does that answer your question?
Yeah, does that help, Tom?
Yeah, that kind of, yeah, I figured I'd just ask you that question before we went back from the break. Apologize for the lengthy question. Thanks a lot for your help, Ken.
So there is a question in the chat having to do with Rover as a service, and can an employer pay for it? And are there any HIPAA concerns?
Yeah, an employer definitely can pay for it. You know, like I've said, usually it's kind of a tool that a broker is using in order to move groups along. Whether they want to build that into the fee or maybe one of the fixed fees of the plan really is up to them. Usually the broker maintains the relationship with Rover though. So if they wanted the employer to pay for it, it could probably be worked into the billing somehow.
Yeah, I did actually. I typed in an answer to that, but I realized I'd only sent it to Michael. I didn't send it to the whole group. From the HIPAA perspective, very quickly, the employee signs a HIPAA waiver that allows the data to be used for underwriting purposes only. Usually that information goes direct to you as the broker or to the TPA, whoever's marketing stop loss. The details aren't generally shared with the plan sponsor. That's up to you. Sometimes it's more shared at an aggregated or summarized level, in which case there's type of protection there. And as usual, and kind of what I was getting to that earlier, the employer's got to wear 2 hats, right? They're HR, and then they're also making this plan operator decision. And they have
Is
to be
Rover an online portal that the employee goes into to get the data?
I believe so the employee and the member doesn't have to do anything other than give the login information.
Okay.
They do not have to take any action other than that. And Rover actually provides services where they will be member facing and they will, alongside the employer at the employer's behest, communicate with members and say, hey, this is exactly what we need from you. So yeah, the idea is to keep the lift on the member very, very minimal, which to the point that somebody made in the chat, I believe it was Gerald, if one member doesn't participate, then it can throw off the whole thing.
So that is the issue. You have to get 100% participation.
Yeah, you have to get participation for sure.
Now, are any of these similar to like a middleman where they're checking the pharmacy on these individuals? Do you do that? Or, I mean, because, what's the percentage that something like middleman is helpful in the underwriting?
It's a great question. So I think Grant highlighted an organization called Radion. They and others are taking demographic information, name, address, right, for everybody, and they're mining claim databases similar to the old Curve or GRX underwriting, what used to be called GRX underwriting, where they're looking for things like large pharmacy claims, trying to use that to predict future expenses.
With your company, just as an example, if you had to weight what that data is towards your underwriting, how credible is that data?
That's really a question for them. I leave that to their actuaries and algorithmic people because it's beyond my pay grade. The larger the group, the more credible it is. And there are certain states where you can't get claim data, in excess until you get in excess of 200 or 300 employees. Like California, as an example, and Florida both, there are very spotty responses to data requests. So it's, I would say certain underwriters have placed a lot of weight in what those organizations are doing, right? So you'll find a couple that are willing to give it a good deal of credibility, but not everybody.
Yeah. Thank you for these questions. I do want to make sure that we hit this this second module though. So again, I'll start us, and then if there are more questions, please put them in the chat, and we'll try and address them at the end. So the final module that we want to go over today is really, I want to address 4 very specific, what I would call funding arrangements. They're not plans, they're just funding arrangements. I want you to be able to know about each, really understand when to and when not to use each. These we get questions and we get misconceptions around these things all the time, which is why I built them in. I will start this module with a reminder though, this is from yesterday, to find a mentor. If this is something that's interesting you, if it's not, if this really doesn't sound like it's for you, then like grab your CE credits and go, that's perfect. But if this information and what we're talking about here really is something that interests you and is piquing your mind and saying, oh my gosh, I could use this in my career, I could use this for myself, then yeah, absolutely dive deeper and get a mentor, somebody who can help you start and who can answer questions. It's very important, and a lot of damage could be done in these environments if if you don't know what you're doing. So I want to dive right in here to first kind of break out the 4 types of funding arrangements that we're going to talk about. The first one is PEOs, professional employer organizations. And this is when, for anybody who's not familiar, this is essentially a co-employment relationship between the group and the PEO. The members, I think even technically and legally, are employees of the PEO. They're not actually employees of the company. This creates kind of a very, very simple and streamlined way for a company, usually smaller, a little bit less sophisticated, to be able to provide things like payroll and benefits, workman's comp, HR support and consultation, and even light legal work for the group. So when we're looking at this, what we are really looking for is groups that are, probably under 100. That's when a PEO tends to make sense. Groups that don't have any data, can't really get their hands on data. A PEO is not going to help you get data, by the way. I would say one of the problems with PEOs is that you leave a PEO and you have 0 data for yourself. But it has some pros. And then you're going to want to filter out groups that are in multiple kinds of locations. You could find a group has the PEO is not available in certain states where employees live. That can be a real problem. And it's not a high risk, high reward type arrangement. There's not going to be a lot of reward in the group for going this way. But what you do get are things like better buying power, a rate that you could not get on your own as a group of that size. You're going to get a lot more plan options to be able to offer to your people. Again, things that you just really couldn't afford or wouldn't be able to put together on your own. I would say a couple of the cons about these things is that, like I was saying, it's not a high risk, high reward type environment. There's really no, you don't have a lot of say in some of these levers that we were talking about pulling. If you have a really good year, you are self-funded, but you're not reaping the benefits of that good year. The opposite of that is if you have a bad year, the risk is mitigated, but there's really no reward for a good year. As the PEO performs, so you perform. So again, it's a little bit of risk mitigation and kind of a light step into being able to offer benefits for a group that might not otherwise be able to do so. And leaving is difficult. This is something that I mentioned before. It's difficult to leave a PEO. You're really not gathering data throughout the plan year. You are, when you leave a PEO, and we have clients who do this, and groups we're talking to right now even, you're really starting from square one as far as group data. You're probably a group that has grown significantly in a very short amount of time. The group probably has other HR concerns as well. So being an advisor for a group that's in a PEO and wanting to leave can be really tricky. There's no group data for marketing. The group probably doesn't have people on staff or full-time employees who are dedicated to this. They probably don't have policies, internal policies in place for leave or even for benefits that are going to really be conducive to building a really good self-funded plan. So that's something that, as the advisor, that's an opportunity to walk them through and again, bring value to the company by really guiding them through that transition process. And so, yeah, leaving a PEO can be difficult as well. So this is sort of the lowest risk, easiest thing to step into. Again, really focused for groups kind of under 100 employees. Does anybody have any questions about this arrangement? Beautiful. Great. So the second thing that I want to talk about is captives, and I'm going to get Kevin to join in here because captives they come up quite a lot. You know, the idea is that like-minded companies would go in together, share risk and share reward together. So Kevin, can you talk a little bit about high level, what's a captive? What does it do? How does it work? Things like that. Oh, you're muted.
Sorry, a little background noise. Yeah, if you're familiar with property, the World Property and Casualty, the health insurance industry borrowed this, right? Healthcare borrowed that concept of captives, and captives generally are a group of like-minded employers that come together because they feel like they can reduce their overall exposure by implementing certain risk management costs, right? We're going to address, and everyone can do the same thing, right? So we all buy in that these are tools that we can use to improve our results, and then share in some of the rewards, right? So rather than just paying a stop loss insurer for specific coverage,
I'm still in the call. Nice meeting.
we get the opportunity to get some of those dollars back, right? If we have a profitable year. If an employer is participating in those profits and losses, meaning they get a share of their premium back if the group is successful, they will almost always be asked to put up collateral as a result, invest in their own insurance company. Now, the advantage in the healthcare space is that, generally speaking, the tail is very short, right? Work compensation, very long tail. You can have a claim that drags on for 5 years. General liability can have suits that go for a very long time as well. Healthcare, generally, we know everything within 3, 4, or 5 months, right? It's unusual that we get a large claim or a claim of any significance after 120 days post date of service. So the collateral is usually less than what you're used to in a rental captive on the property and casualty side, right? But the components of it are the same. Other components are the same. I band together. I get to be treated as a much larger employer. I get, even though I'm individually underwritten, I get the consideration of being part of a larger group, similar to PEO, right? So when I have a bad year or I have an ongoing claimant, the captive as a whole can swallow some of that cost and it doesn't blow up my claim. The offset is higher fixed cost up front because you're going to have to invest collateral in most of them, though not all of them. In most of them, you do have to pay attention to that, right? And generally, captive programs have a philosophy of no new laser at renewal, so they can be negotiated, right? And then I have the opportunity to capture profit if the group as a whole succeeds.
So let's talk a little bit about what kind of groups are right for captives. We've got some information up here. A captive, I think, helps to lower risk. It's a risk containment vehicle, and generally size-wise, you're looking for groups that are maybe 25 to 300 enrolled. Why does this make for good captive prospects, Kevin?
Yeah, again, because you're spreading the risk across a larger group, right? So one of the concerns, and it's a legitimate concern that people have when they move to self-funding and they're smaller, is that, what happens if I have one big claim? And it's usually not the one big claim that causes a problem. It's the one big ongoing claim that's still there when you're going to renewal, right? Insurance is about paying that one big claim that nobody expected. That's what we do for a living, right? That's kind of the where the road meets the road. However, when we have that known claim where a laser would be in play, so it spreads that risk for smaller groups, and it makes it a little bit easier for them to continue with the program. So they don't have a scenario where they are going to get kicked out. And if I have that year that's not great, it's muted by the fact that I'm part of an organization that has 2,000, 3,000, 5,000 employees instead of just my 100 folks. Okay. And I think to the question about collateral and some of the fees that are associated with captives, right? Once you get to about 300 enrolled employees, you're fairly credible and you can stand on your own. You can weather the ups and downs. You can on your own. You don't need that support, that broader group as much. So the fixed costs that you pay to be part of the captive kind of become lost money as you get to be larger, right? And that's why it caps out around that number for me, as far as your recommendation.
Yeah, at about 300, the economics of being a member of a captive don't make sense anymore.
And the captives, most of them will tell you that they don't like that because if or when that employer, is bought or sold or leaves for whatever reason, there's a huge hit to the organization, the captive as a whole, when they leave, right? Losing one large employer in a captive full of 25, 30, 50, 100 employee companies is a struggle for them financially.
Yeah, absolutely. And then one of the filters here is groups that wouldn't seem to have a lot of data or good data. Can you talk about maybe kind of what are the data requirements? What do people need to know about groups in order for them to be good captive?
Yeah, I mean, so captives were built primarily to pull those smaller, groups out of fully insured programs, or groups in that 100 to 200 employee range and down out of fully insured programs where they didn't have access to data. So most organizations that offer a captive solution do it with the mindset that people are coming with no data. So they're more willing to underwrite using shadow pricing off of the renewal history of the group. They may be more comfortable using services like a Verify or risk prediction, someone mentioned Milliman, those types of things, because they know that their target market is coming oftentimes without data. So, however, they are like any other stop loss risk taker, right? It's just a different version of stop loss with some rewards and benefits for smaller groups, right? So it's just the same. I always want people to take that step back and realize it's really no different. There's just a difference in how the risk is shared across the group in that captive layer. And that gives me an opportunity to win another way.
Right. Yeah.
So it's all the same, right? So the more data we can provide, we can have claims history, those things, it all works to the benefit of the underwriter to put better rates on the table.
Yeah. So if we're looking at pros of groups being in the captive, one is at a certain size, it's very easy to enter the self-funded market. It gives you a nice place to go and step into. I would say that on the, as you can kind of see on the screen here, there's an element of expert risk mitigation. This is a group of companies who have decided that they're like-minded enough in how they want to approach their plan design. Usually that comes with a lot of plan design. Usually it's what we're talking about here, thinking critically about what's driving cost, thinking critically about, for all of these groups, what are the ways that we can help bring that risk down? So people who get into, or groups that get into captives, tend to benefit from the fact that the captive has already thought about the plan design. If you are a good fit for this captive, you can kind of benefit from that expertise there.
No doubt. Just not every captive has those requirements, but the best performing ones do.
Yeah. We actually had a question, two questions. One, claims are shared among the members. Is this correct?
In that captive layer, yes. Right. So essentially what you're doing is buying into an insurance company and your captive is taking some of the risk, right? I might have a $25,000 specific deductible because I've got 40 employees. And the captive itself, right, is taking the difference between 40 and 250 or 40 and 500,000. And that's where we all participate as a whole, right? And then there's a reinsurance above that to take care of the catastrophic stuff.
Yeah, absolutely. There was another question in the chat. Do you offer captives? I guess does Flume? Flume does not have a captive. However, we are connected with and associated with several. So if this was something that there was a group that was interested in this, it's certainly something that Flume could point in the right direction. We administer groups who are parts of captives. The way to think about it is this is a financial arrangement of the plan. Whether a group is in a captive or not, it should not really affect the way that the TPA gets involved.
Yeah, captive is a great way for a broker consultant to put together a program that they want to own and sell to the market. And those are the ones that we most often see as prescriptive, right?
Yeah.
Going to be this TPA, this PBM, these cost containment tools in place, and then it's your own.
Yeah, absolutely. Another thing that I would address about the captive is the shared underwriting profits. So Kev, do you want to talk a little bit about kind of the premium refund if the captive is profitable?
Yeah, make sure we keep this on track too. But as we've described, because if I'm asked to contribute collateral, right, as a plan sponsor, generally speaking, that means it comes with the opportunity to reap some profit back, right? If the captive performs as expected or better than expected, I'm going to get some portion of the premium dollars I've contributed to that captive layer back as profit sharing. It also means it comes with risk, right? So not only are my claims dollars at risk as we would normally have in a traditional program, the collateral I have has to be at risk for that to work too. So if the plan performs at the worst possible level, right, then my collateral is gone, and then we all have to collateralize as a group, the captive. And that's when, has it happened? It has happened. Fortunately, I've not been involved in any of those, but that's the risk that you take, right? So just like investing in the stock market, I put my money into the market. If it goes up, I get rewarded. If it goes down, I have to put more in. Yeah.
And then that's actually one of the cons I would say to enrolling in this is you could lose your collateral if the captive performs poorly. You're out more than just the claims costs because there's collateral there. Also, if you try to leave, I think there's a collateral expense for leaving the captive.
So it's a great point. And I mentioned earlier that the tail in healthcare is much different than it is for things like workers' compensation or general liability, right? It's much shorter. Usually what happens is if you leave, in many captives, there are common entry dates and common exit dates, right? So if you're going to get out, you're either going to get out on January 1st, you can get out on July 1st, right? And then there's a window during which they're going to calculate the performance for that cohort. And then you're going to get whatever portion of your collateral back that you deserve, right? Or is available to be reimbursed. I'll note here that there are some organizations, East Coast Underwriters comes to mind, that have captive programs that they underwrite and treat like a captive. They may have some basic prescription about what you're doing to manage risk, but they don't require collateral investment. So the difference is that entity has collateralized the captive for their own purposes, and they keep the profit of the captive layer, right? So keep an eye out for those two. They exist, and they're really just another alternative.
And I think I don't know if it's the other side of the coin to leaving a captive is there's a risk that you could get kicked out if your group is not keeping up, if you're refusing the risk mitigation tactics that are a part of it. Maybe
Sure.
some other ways, but you could be asked to leave the captive, right?
Yeah, I mean, I think everyone, well, I don't think most employers approach it from the perspective. Otherwise, they might not do it in the first place. But yeah, I mean, if you have a 40-employee company and all of a sudden you've got a male hemophiliac that's spending $2 million a year for the good of the program, the likelihood is that if you're not asked to leave, you'll receive renewal terms that encourage you to do so.
Yeah, and I think the other side of that is, going back up to the expert risk mitigation, if you as a group decide that you don't want to participate in some of the risk mitigation tactics that are built into the captive, there's also the risk that you're not fitting into that captive anymore, and it might not be the environment for you.
Yeah, you're not ready.
Yeah.
Go according to run.
Yeah. So there is a little bit of a compulsory usage of certain things if you're part of a captive. So moving forward a little bit to level funding, I think level funding, other than reference-based pricing, which we're going to talk about next, I think level funding is something that I hear a lot of misconceptions from advisors and brokers on, sort of misunderstanding. If we want to be like hypercritical about it, level funding was something that was kind of invented by the carriers who recognized that employers were trying to get to self-funding, and level funding was something that was created to keep them inside of the carrier rather than letting them go. It's essentially just a mechanism that levels the monthly bills from the claims fund. You can do the same thing with your air conditioning. It just makes sure that every month, it just makes sure that every month you have a flat bill. It's not a savings tactic. It's not a plan design. It's not all that particularly brilliant. but there's a certain group that it's good for. But Kev, you were talking about there's two different types of level funding with a spec and an ag only. Do you want to kind of talk a little bit about the level funding breakdown?
Yeah, I'll start up on a soapbox because I've been saying for quite a long time within the industry that there's a misconception that level funding is somehow different than a self-funded health plan, and the reality is it is exactly the same, right? The plan sponsor has all the same obligations and responsibilities. There's no difference between being a 300 employee company with a specific deductible plus aggregate coverage and level funding my healthcare. They're both self-funded plans, period, end of story, right? And the obligations thereof are equal. So I think a lot of people get caught in the trap of thinking, well, the carrier administered level funded plan, it's not really a self-funded health plan. And the answer is it absolutely is, and you do all the same things. So I'll get off the soapbox there.
Well, I think that's
just a method to as you indicated, Grant, even out the cash flow. So generally to check the smaller employers. It's also very, it can be very useful for organizations that are slightly larger but have seasonal income, right? And they benefit from smoothing things out across the year, right? They get all their money in January, February, March, and they need to make it last all year.
Yeah.
So those are the two key components, right? It's a very easy step into becoming self-funded for employers that are only used to buying fully insured plans. It looks, feels, walks, talks very much the same, but it is different, right? It is self-funded.
I think you kind of made the point, but I say this all the time. It's level funding, or like to me, it's very, very similar to like an ASO plan through a BUCA, which is that people think there's something going on that's really helpful to them. It's purely a financial arrangement. And even in the BUCA ASO type environment, there's lots of limits on what you can and can't do. You still have to play by the BUCA's rules. And so, you're kind of in this environment where, okay, you're asking me to take all the risk and self-fund this plan, but you're telling me what risk mitigation tactics I can and can't use.
Right.
That doesn't really work for me. So the same when I hear groups buying like Cigna level funding and things like that, and feeling like maybe they're getting something amazing, they're really not, because Cigna has foisted the risk onto them. And all they have to do is just level.
Under control. Right. All the risk is under the control. Right. So, I mean, obviously there's caps and things like that. And I think someone made a comment that, the carrier administered plans are going to keep some portion of what's left over. Why do employers do this? Okay. So why do employers do it? One, they can get underwritten in other circumstances where they may not be able to do, so they have to deal with community rates. Two, they want to take that step towards being in a self-funded environment, get data, and potentially keep their money if they win, right? If I don't pay the claims, I don't pay the claims. The key to keep in mind with the carrier programs is generally they're going to keep anywhere, and it depends on the carrier and depends on the region, they're going to keep 30 to 50% of the money that's left in your claim account if you have a good year.
Yeah.
Now, independent programs like those administered by them and other TPAs, right? Generally speaking, give all of that money back to the plan sponsor, right? It's their money. It should be theirs to keep. Now, obviously, there are advantages to being in a carrier program. You've got the logo on the card, and all that all goes with it, right? There are two programs to keep an eye out for. Usually, they're either aggregate only. The risk with aggregate only, it means you're just paying the claim funding factors on a monthly basis plus fixed cost. But one large claim can wipe out the entire claim pool for a smaller group, right? So you can have a spinal surgery that for a 45 employee company, more or less takes up the entire claim fund for the whole year. An alternative to that has an internal specific deductible built into it, and it protects the claim fund. Now, let's keep in mind that these are generally going to be very slow, specific, $15,000, $25,000, $30,000, right? But even then, for smaller groups, that really quickly wipes out the claim funds.
Yeah, I would say you do have the risk of the high claims, and then I think it was Gerald in the comments section again, you need to really watch out for ambiguous terms in the level funded plan. You could wind up giving away all of your savings. You could wind up giving away half of your savings. And I mean, this goes with This goes with the PEO. I think somebody made also that comment as well. This goes with anything. I mean, probably one of the biggest places that we uncover misspend and overspend is just that employers are not trained and they're not equipped to actually be reading and understanding the terms of the contracts they're signing. So whether that's with fully insured or whether that's through an independent TPA running reference-based pricing, right? Two complete opposite ends of the spectrum. Are the terms of the plan that you are running favorable to you? Are they making sure that your coupons are being passed back from the pharmacy? Are they making sure that no kickbacks are being given for stop loss to any of the vendors? Are they making sure that you're keeping the money that you are saving? As the risk mitigation tactics you are performing coming back into your pocket? So this doesn't just go for PEOs and level funding, it goes for every single piece of the plan. It must be read with a high degree of scrutiny and transparency. And that lack of transparency is one of the things that's really contributing to the rising costs. Everybody's taking a piece of the pie. As advisors, again, value to bring to clients is to say, let me review your contracts. Let me show you, let me circle it in a red line where you're overpaying and find out whether you're aware that this money's leaving your bank account or not.
Right.
Yeah.
One more thing, before we move on from level funding, one more thing. I think a lot of people fall into the trap of thinking that because this is carrier administered, it's going to behave like a fully insured plan, or they're going to treat it like a fully insured plan. And here's what happens. I've seen this a couple of times, and it's always very uncomfortable. It is a self-funded plan with stop loss coverage. And when you terminate that mid-year, the stop loss coverage goes away, not just for claims incurred and run out, but for anything, right? It's done, it's over. And I've seen employers get stuck holding the bag for claims that were incurred when they decided they wanted to make a change mid-year, not on the anniversary, and run out wasn't contemplated. So don't fall into that trap. It will not work the way your fully insured United plan works, right? And for smaller employers that are generally part of this program, a $40,000 bill for an appendectomy is a big deal. So
Yeah, thank you.
that in mind.
So this is the last piece of our presentation, save the best for last. This is where we get the most questions. What I would consider to be some of the most misconceptions is around reference-based pricing. This is something that Kevin has a ton of experience in. I think having gotten in with reference-based pricing on the ground floor when it kind of came into being, it was something that Flume, in Flume's very early days, we were started kind of to be very hyper-focused on reference-based pricing, and we developed some unique technologies that were making it really easy to run such programs. We've now expanded beyond that, and reference-based pricing is a piece of our book. We're by no means, a reference-based pricing company, but we do want to talk about it and bring it up because it's something that I think a lot of brokers try to jump to. They want to get the client there because there's a lot of savings there, but that can be disastrous, as I was saying earlier. This is 100 miles an hour. You need to crawl, walk, run, or however you want to phrase it. If you go from 0 to 100, that's not acceleration, that's a wreck. So reference-based pricing should really just be viewed as a blunt instrument that breaks through the walls that have been erected between patients and providers. The goal is transparency in quality and price. You see that I did not even list savings as a goal here of the plan. A goal of reference-based pricing, a much better goal should be transparency in quality and price. It anchors the rates that you're paying into the Medicare system, and it helps groups. It's a tool or a tactic that can be used to help groups leave a broken system. Now, the group has to believe that the system is broken in the first place. The group has to want to be leaving that system and want to take on all of the burden that's going to come with leaving that particular system. I think a lot of times I've seen reference-based pricing plans sold without that piece, and that's a super important piece. The group is sold on the savings, and they don't understand anything about the fact that they are leaving a very well-established medical system. And if it's not done properly, within a year, the broker's fired, the TPA is fired, the plan's back on fully insured, and the group has been set back years because their goal to get to transparency and quality and price, it has now been set back. So again, if we're looking at the types of groups that reference-based pricing is good for is you're going to want to find disruptor groups. You're going to want to find groups that I would say have been prepared. Flume kind of as a rule really doesn't take on first-year RBP clients that haven't been walking towards that for a little while. It's just not something that we're willing to entertain. And so brokers come to us and say, I want to take a group to RBP. The first question is, okay, well, what's the situation right now? If you say fully insured, we can talk about getting there, but we're not going to take them their first year. So a group really needs to be a disruptor. They need to be looking for a high risk, high reward type environment because there is reward, there is savings, 20 to 30% savings. And that's proven across the board. Reduce long-term medical costs on the inflation that equals Medicare. There's a lot of reward to being in a reference-based pricing plan. However, there's cons to it as well, which we'll get to. I think what you're not looking for are groups that are spread about geographically. That's probably one of the red flags for an RBP candidate. You need that population center to really be able to drive direct contracts, to really be able to make it easy on the plan to administer in the group. And you really don't want a smaller group. Reference-based pricing you can get some balanced bills, you can have some crazy things happen. And so usually the larger the group, the more sophisticated their operations and organization is, the better kind of candidate they are for something like this. Kev, do you have anything that you want to add to that?
Well, I'll just expand on kind of what you said earlier, and that was, who are the good candidates for this? And I think we as an organization have become much more prescriptive about the way to succeed with a reference-based program. And it's not usually the first year with Flume, right? When these things go bad, and Grant alluded to it earlier, it's because people aren't prepared for the first 90 days of disruption to patient access. And there will be people that have trouble getting to see their doctor. They may be able to get them to a doctor, but they may not be theirs. And frequently, those people are in the system, right? They have 3 or 4 comorbidities. They've got a lot of stuff going on, and they're anxious. You know that they're anxious if you change from Blue Cross Blue Shield to United or United to Aetna, right? And it's heightened when we take them into an uncomfortable and unfamiliar environment where they can go anywhere, but a doctor may not know what's going on, right? So, all of that goes back onto the program and usually lands at the feet of the TPA. And even though, they or we could be doing a fantastic job getting people seen, it takes time. And if the relationship between the TPA, the broker, and the plan sponsor isn't already solid, and the relationship between the TPA and the patient hasn't already proven to be successful in years past, it can lead to disaster. And I think building that relationship with an organization over time, where we begin to teach them about the things, the levers that they can pull, some of which are disruptive to patients, some of which are all behind the scenes. There's a strategy to doing it and doing it well, I guess is what I'm trying to say. And that should be considered.
Yeah. I mean, the point to that you're making is that the group does have an unprecedented amount of control and say in their plan design. They have full control over what is covered, how it's covered, what they want to pay. They're going to need to find arrangements that are going to work. But this is for groups that really want to get down into the nitty gritty of how their plan is run and designed. And there are definitely employer groups like that. More and more of them, as their C-suites are kind of waking up to the fact that this is a sleeping bear of financial liability, their health plans are. The cons, the drawbacks to it are the access issues that you mentioned and the balance bills, which, I just want to be really clear. Balance bills are a real thing. People get surprise bills and balance bills in a fully insured environment. If you have a surgery, your anesthesiologist might be out of network and you've just received a balance bill. And you can have that with Blue Cross as easily as you could with a self-funded plan. So balance bills by the numbers, statistically speaking, are rare. They feel like they're a lot because you hear about them. The squeaky wheel gets the grease. On a standard plan, most people aren't using the plan in any significant way anyway. And then most of them are the small group that tend to have things that are coming down the pike. And so you can kind of be proactive and mitigate the access issues there. But balance bills do arise And there's multiple ways to kind of handle those things, which we, is a little bit outside of the scope of this conversation, about how to handle them. If they're not handled correctly, though, if a TPA and a repricer do not have a good method and way for addressing and handling balance bills, they can get out of hand quickly. They can become legal liabilities. They can become big financial liabilities. It can really disrupt a member's life. The flip side of that is there are a lot of scare tactics that hospitals and providers use, which I think is pretty morally reprehensible. There's a lot of scare tactics that hospitals and providers use to try to bring reference-based pricing to an end, or to try to make sure that they are collecting on things. There's all kinds of stories there. But yeah, the billing is really important to get right in a reference-based pricing plan, and it will be a point of it will be a roadblock to a smooth plan operation. Kev, do you want to add anything to that?
No, I think there's a lot of concern about balance bills because everyone can see or can conceive of a very large. Okay, so let's say we had a $1.7 million billed COVID patients, right? And people think about that and they say, oh my gosh, Medicare would have paid 50 grand or whatever the small number is, right? So some ridiculous amount, and they're concerned about the spread there. Do those things happen? They're a possibility, but they're really even the far greater frequency of balance bills in the plans we administer are small claims, right? And those generally are easy to make go away.
Yeah, I think the stats for Flume is that 80% of our balance bills are solved in one phone call.
Yeah. But where balance bills can have a dramatic negative effect on a plan, RVP plan, I see them as the nail in the coffin, right? If the access issue, if the plan isn't set up right, isn't installed properly, you have access issues in the first 90 to 120 days, HR's on your back. They've got people that are screaming at them. And then when the few balance bills do start to arise 6 to 9 months later, they're like, we're done. This is too much. We can't handle this. And that's how RVP.
Yeah. So I'll open it for question. I want to land the plane because it's exactly time. So we have one quiz question. I have to ask you 2 questions per module in order for you to get your CE credit. So I'm prioritizing this over questions from the group. True or false? You can answer this in the chat. Level funded is a very specific type of plan design with rules around the types of risk mitigation tactics a client can and can't use. You can just write true or false there. We got some answers coming in. Man. All right, so the answers are coming in. Unfortunately, I am seeing a lot of trues here, which is not the correct answer. You may be thinking of a captive, which may or may not have some rules, but level funding is a strict financial arrangement. All level funding means is that you get one uniform bill every month, and then you true up at the end of the year. Level funding has nothing to do with plan design rules. It has nothing to do with risk mitigation. It has nothing to do with saying what you can and can't use on your plan. So the answer to quiz question number 2 was false. So really quick, this is the same points as above, but all of these things that we're talking about today are things that your TPA can and should be playing a role in. They should be contributing to the plan build. They should be making sure that the regulatory standings are keeping good. They should even be doing light direct contracting and repricing for some of the reference-based pricing groups. You know, when it comes to summing up these ideas, you want to know your options. You need to be familiar with these funding arrangements so you can bring ideas to the table. Do not rush reference-based pricing. It can be an effective tool, but the CEO, the HR, and the broker all need to be very aligned and very structurally sound before going into it. And, you know, my recommendation I made a bunch of times, get a mentor, lean on your mentor for guidance when you're getting started in all of this. We will provide all of the resources to Karen afterwards, which she'll distribute. Again, I'm Grant Parker. I'm with Flume on the sales enablement side, and we've had Kevin, who is our Chief Client Officer at Flume. This is our contact information if you want to reach out and ask any follow-up questions and anything like that. I really welcome it. I'd like to hear from you. We are officially closed for the lesson. If anybody wants to hang around and ask questions, I do believe I've got a little bit of time here, so I'm happy to do it. Otherwise, you can feel free to send us an email or even old-fashioned call us.
I do have to drop. I want to thank everybody for your time and attention. Appreciate the engagement and attention.
Kevin,
Thanks, Grant. Thanks, Karen. Have a great day.
Yeah.
thanks so much.
Yeah, if there's anything that anybody wants to chat about or talk about.
When Flume works with reference-based pricing plans, and the doctor or the hospital doesn't accept the negotiated fee, this is what you were referencing as the balance billing, is that correct?
Yes.
Okay, what service do you use? Like, do you go back if it's not if they're not accepting it? There's certain programs out there. I mean, NatGen, now it's all state, they're very good at it as far as how they've approached it. But there's a lot of companies, it just doesn't work well. I've never had good experience with reference-based pricing. I always find that it's good for lower income employers, larger factory type of environments. But how does Flume work with, when the negotiated fees? Do you work with the employee? Do you have a service that goes out and negotiates this further?
Yeah, good question. I mean, the first thing that I'll say about reference-based pricing is that in our experience, it has proven to be pretty regionally specific. There are certain regions that tend to have a lot of reference-based pricing, and there's not really a ton of access issues, and the providers are open to it. There are other regions where that's not the case, and the hospitals have really tried to clamp down. I think these regions tend to move a lot. They tend to fluctuate. If you ask 3 brokers in Texas, is Texas a good RBP state? You'll probably get 3 different answers. I think one of the answers to your question, and I feel like I'm always answering these questions in this way, is it depends. It depends on what kind of repricing or reference-based pricing partner the plan has in place, right? So you could go with someone like EBSO, who takes a little bit more of a litigious approach to balance bill, and they're part of what you're paying EBSO for is full and complete legal coverage from the liability. And EBSO's immediate response to every balance bill is a letter from a lawyer saying you better accept this or else. And they've got networks that they bring people to of direct contracts and rates above Medicare and things. You've got partners like AMPS who are a little bit on the different side. They spend a lot of resources developing direct contract networks in the areas where they have good contracts. If you put a reference-based pricing program into place, you're not likely to incur a lot of balance bills because AMP's done that legwork, and they've got they have a team of negotiators and member experience people who are participating in that. Flume has a team of concierge people. Generally Flume personally gets involved at that lowest level, the single phone call to the doctor saying, hey, you billed this is what the plan pays, want to clear this up. And like I said, 80% of balance bill issues are solved in our experience in that single phone call. And then from there, it escalates to whatever the third party has been put in place on the plan. So Flume as the TPA takes a pretty small part of the member experience, and then the rest of it, it depends on which of the repricing partners has been built into that plan and how the plan sponsors wanted the response to be. Some plan sponsors don't like the idea of a litigious approach, and EBSO would not have been a good partner to put them with. Some plan sponsors really want that. So when I get questions all the time about reference pricing, the answer is it depends on what the plan sponsor wants. Like I said, you have a very serious degree of control into how your plan is run, and all of this should be talked about. That's why it takes multiple years to get to this point.
You write hybrid plans, traditional plans along with the reference-based, and do you have like minimums to some of them you have to have 25%, 25 people in order to get, do you have the same criteria? And then what networks are you able to use
Yeah.
for the hybrids?
Yeah, the network, this goes back to the slide that I had up yesterday. The network is going to be the biggest determining factor in what you can and can't build into your plans. With Cigna, for example, definitely not. They don't allow side-by-side plans. But with First Health or the PHCS PPO, you can do that. So we do have groups that are offering both side-by-side. You need to be careful in how you set it up to avoid exposure to discrimination liability. As far as minimum enrollments, I do not know the answer to that question. There very well could be, but I haven't been personally involved with anything like that. So I have to say I don't know. Good questions though. Anybody else have oh wait, there's some things in the chat here. Oh, those are just more answers to the quiz. Yeah, anybody else have any more questions about this or anything that we've talked about the last couple of days?
Grant,
just
you and I
wanted
have, I'm sorry.
Sorry, Gerald. Go
Grant,
ahead.
you and I spoke previously, is that correct?
Yes, I believe so.
Okay, we should have a follow-up phone call.
Yeah.
I don't know, I don't think that one was such a great phone call, but all right. I think we should have a follow-up phone call on other aspects of Flume.
Sure, absolutely. Yeah, I totally agree. I'll make
So
sure.
if there is anyone on the call who would like to have a follow-up call with Flume or talk any further about our topic of today, I'm happy to set that up. You just have to
Sure.
contact me and we'll get some conversation going. It's a lively topic. I think it's real timely because of the way the market is fluxing so much. So anytime you guys want to put that, are interested, I'm happy to do that.
Yeah, thank you. Thank you.
All right, so I'll confirm that Grant's going to send over the material that he used in the last 2 days for our CEs. I will get your forms posted on over to Steve. And anything else you guys want or need or are looking for us to do for you, we're happy to try that. Just a comment to Gerald's on reference-based pricing. We have several reference-based pricing carriers, clients, I should say. And mainstay in all of them is what's the legal team behind it, the reputation behind the repricing group, whoever they are, and how do they go about doing that? And Grant, you made a perfect point when you said some of them take a litigious approach and some of them do not. They're looking to help the employee pay this bill. So there are a lot of ways to work with it. We found, for the most part, it's accepted. The groups I have are not all blue collar. When you're talking money, you are really affecting an employee's paycheck. So we're finding it to be accepted into all kinds of industries.
Grant, I have
that's
another question. Grant, I have another question.
Sure.
So you have a reference-based pricing and it's going to work primarily. I mean, it's going to work well for 95, 98% of the population. Is there any way you could set up any type of out-of-contract arrangement or some special arrangement for the few instances that you do have those issues?
Do you mean like direct contracting with the providers that those members are going to?
No, an out-of-contract situation with the employer, with the claims going into the claims account in some way, where it gets paid, where the employer can compensate or the employee can be reimbursed. Do you follow what I'm saying with out-of-contract situations?
Yeah, I'm not entirely certain. That's a level of detail beneath my pay grade. Certainly Kevin would know. I think if it's important to you, we can definitely have a follow-up conversation about it. Yeah, that would be my answer. The only place my mind also goes when I'm thinking about that is just building the plan is in place for employees. So you can make it so that the plan language specifies that if employees use the nurse navigator line to book or to find their providers, that their deductibles will be waived, things like that. Like you can do things that will help employees on a financial perspective that are built into the plan design. But specifically what you're talking about, I think is a little bit above my head.
Well, for the most part, when you're designing plan designs in this world of reference-based pricing, you can be, you're working with a stop loss carrier, they're insuring a risk. You can determine, the employer can determine, well, what do I want to encourage? To your point, I know WellNet has this really great program where they do the same thing. They can build the plan so that if your employees utilize their nurse concierge service or whatever, there's a zero copay.
Right.
You can basically have a zero plan if they're using their negotiations. But on the same side, they can go where they want with the plan design that they currently have. So we put a lot of that choice in there to the employee. So it's at time of service, you use this, you use door 1, this is what you're going to have. You have door 2, this is what you're going to have.
Yeah.
In another group, I've got a similar thing where we negotiated 5 clinics and urgent care centers around the location of the group, and encouraged they could go there for $10. Otherwise, it's a deductible coinsurance, high deductible plan, gave them first dollar generic bills. And the utilization on it has been spectacular and the claims have been amazing. So I think it's all in the plan design, Gerald. I think it has a lot to do with the TPA you're utilizing. I think it's going to be, what kind of risks are we talking about with a stop loss carrier involved? Who absolutely is managing that negotiation on the claims end, whether it's an ELAP or it's a whoever, who's doing that and in what method do they do that?
Right.
What's the accountability behind the door? And so that's what's going on with that stuff. So all of the above can be accommodated.
Yeah.
Grant
Very
hit on it. You hit upon it a few times. If you can't educate the employees on these programs, it's not going to work.
Right. Don't
Nope.
do it.
It's just not going to work. You have to have open lines. You have to have somebody available at the company to guide the people, because it's a completely different way to access benefits. And if you can't do that, don't sell it.
Exactly.
Right?
Exactly. Yeah. So team, I have to,
Right, but
I have to go,
don't you-
unfortunately, 1:15.
Okay.
I think
Just one more comment. Don't you think that this is just one of those, as it becomes more mainstream reference-based pricing, I think you'll get a little less of the pushback.
Yeah, I definitely think I don't know what's going to happen. It's like I said, I see it moving market to market. It picks up and it slows down. And yeah, so I unfortunately, I do have to go. It's 1:15. Thank you so much. I will make sure all of these resources to you, and you have my contact information. I really appreciate all of your attention and your thoughtful questions. This has been great.
Thanks so much, Grant. Really appreciate you.
Bye,
Talk to you soon.
everybody.
Sure.
Bye, Karen.